Hey guys, just wanted to do a quick video to review a protocol that is going to be coming out officially today. We did get informal notice from the state that all of our protocols have been approved, and we should have that formal notice at the start of the week. But this particular protocol is time sensitive for a few reasons, which we'll talk about in just a minute with the epi shortage that's happening. So cardiac arrest, going to be some changes coming to the way that we are running these in regards to medication administration. So just want to hit the high spots and review these with you. They've already been added to Dropbox. So you'll see both AC1 and AC8, two sets, the previous ones, but also these have been added so that you can reference them as needed. We've also got printed copies. We'll make sure that everyone's got those on their trucks. All right, let's see what's changed. So obviously none of this top section has changed in regards to compressions and breaths. Defib procedure is the same, and we're looking at the pulseless VFib VTAC protocol. Here's the big thing that's changed. The thing that we want you guys to see is epinephrine. So we are going to transition from a bolus dosing of 1 to 10 epi, and we're now going to change to an epinephrine infusion. Some of you guys may have heard in the field people calling this a dirty epi drip. I had a crew reference yesterday. A nurse asked them, hey, is this a dirty drip? And they were like, I'm glad we talked about that because now I know what it meant. So you may hear that. For the purpose of protocols, anywhere that you see epinephrine infusion, that's what that's going to mean, is this dirty epi drip. So how do you make it, Brenda?
So you get 1 milligram of epi, and then
Does it matter which one it is?
Nope.
Doesn't matter. It can be 1 to 1 or 1 to 10.
Nope. Whatever epi you have in hand, and put it in a full bag of saline. So a 1 liter bag.
So you'll have 1 milligram in 1,000 mLs, give or take, obviously, depending on which epi you use, whether it's 1 to 1 or 1 to 10, but it's going to be a very minute difference in concentration. What that's going to be is your dirty epi drip at that point. Super easy. This is going to run during the entire arrest. So whether it's your IV or IO access, you're going to run this in during the arrest. No need to dose someone with epi as a bolus. So I think we've got to be very careful with that. We've all got muscle memory from years and years of giving epi every 3 to 5 minutes. This replaces that, okay? Can you repeat it? So let's say you get halfway through your arrest, you're at 20 minutes in and you run out of fluid, which means you've given that full milligram of epi. We did add in here that you could repeat once so that you do have that ability to continue administering fluids and epi throughout the duration of an arrest. You do not have to repeat it. You could also opt not to and stop at that 1 milligram. Depends on your patient and your clinical judgment. So let's hop into why would we do this? So a couple of reasons. I want to talk about clinically first. I sent a link out in the full-time group, and I'll be sure to send that out in an email as well to all staff with some information about why epi may not be the best choice or course of action in a cardiac arrest. So the last guidelines, the 2015 ACLS guidelines from AHA, epi is a class 2B recommendation for epi every 3 to 5 minutes as a bolus. There's really not a lot of scientific support that it causes good outcomes. And so that's one reason that we're going to transition. What's another reason?
So, and the other reason is that many studies have seen that just by looking at the outcomes with dosing with epi, especially in ROSC, these studies have seen that, yes, you do get an increase in bringing back that survival, but they don't come back neurologically intact. So, in fact, much of them have poor outcomes overall.
So not a lot of good science on outcomes. We may be getting more of these patients back, but there's not a lot of statistics that are showing that they're coming back neurologically intact. In fact, some of the studies back from 2002 all the way to now show that it creates poor outcomes. So some really good reads there. Again, I encourage you to read those links with all the studies that have been listed since 2002. The next one, and another big one that we're working on, is cognitive offload. So remember when we brought the Lucas on, what that done for everyone in freeing your hands up and giving you more time to think about what would be your next steps in working this cardiac arrest. This is another piece to that puzzle. So one less thing to think about. No one's having to remember, is it time for epi? What's it time for? it's already happening. So we're automating as much as we can to make sure that your mind is able to think about reversible causes or focus on what's next for refractory VFib, VTAC, which obviously is still listed here in this protocol. So you would still work through these meds in the algorithm if you have a VFib or VTAC arrest. What else we got?
So on the other one, it's saying just the avoidance of the post Ross drop in BP. So meaning like once you get them back, most likely this patient is going to be again peri-arrest. Blood pressure is going to be very low. So you already got the dirty epi hanging. So making sure that you're using and utilizing it to up to its capacity.
So you basically have a built-in pressor already hanging. So many times in a cardiac arrest, you get the patient back and you're like, well, their blood pressure is 80/60. What am I going to do? We dump more fluids in. I think a lot of times people may be hesitant to hang a pressor because we don't have a pump, or maybe they're not comfortable with the dial-a-flow. So this takes the guesswork out. Super simple, super safe, very low risk of a dosing error. If you give the patient the whole bag, you've only given them 1 milligram of epi, and so super safe way to have a pressor. Yeah. You're going to see this dirty epi drip in a few other protocols as we release them. So it's going to be something you can use for other patients as well. And then lastly, certainly not as important as all the clinical reasons that we're going to do this, but there is some concern about a national epinephrine shortage. And so that is why this protocol was even considered or developed a few months back. And so there are some counties that are already utilizing this protocol. Cherokee County is one of them in the Western region that's been utilizing this and has had some success. Important, we want to talk about the process. So again, Brenda talked about 1 milligram of epi in 1,000 bag, easy peasy, 10 drop set, wide open rate. You want to talk about how we're going to make it safe and label it.
So Steve has placed an order to label the bags once medication has been added to a saline bag, to label it and make sure that everybody is known in the truck or working the arrest that epi has been added to that saline bag. Until we get those labels in, we have made our own handy dandy labels, and with as big as writing that we could put it in, but it's basically just states EPI Infusion 1 milligram in 1,000 bag of mLs. So just make sure you're putting it on the bag and make sure that once that epi is introduced into the saline bag, everybody running that code knows that there is epi in that bag.
That's definitely the most important part. We certainly wouldn't want to hand off a patient with a bag of saline and someone not label that, and then the hospital thinks that it is saline. So those are going to be in the cardiac arrest pack on Medic One. We've also printed plenty so that each truck can have about 20 labels per truck. So those can go in your drug box. It's most likely that these would be utilized out of the arrest pack, but also as we progress into protocol development and implementation, again, you're going to see this more and more. So you're going to be able to utilize these on other patients. So let's switch to the PEA protocol just so you can see it. No real changes here either, just this epi infusion here. So again, same thing, PEA, asystole, VFib, VTAC, doesn't matter. So what's that going to look like? We're going to come in and start with what? Good BLS. CPR, mechanical, whether it's your Lucas device or if we're doing manual compressions, no different than any other time. We're going to put on a cardiac monitor. So first step CPR, second step cardiac monitor, assess that rhythm. Third step is BVM ventilation. So obviously we're at a 30:2 ratio initially. Access, whether it's IV or IO. Then we're going to look at our epi infusion, 1 milligram and 1 liter. And then we can start thinking about our advanced airway, whether that's an iGel or an ET tube with end-tidal CO2 waveform. Something interesting just to show you the difference and how important other things are as opposed to epi, because I think we're so used to epi and it's the main thing we do in a cardiac arrest. It can feel a little odd not to be giving epi so much, but end-tidal CO2 waveform is a class 1 intervention for patients in cardiac arrest, and that's per AHA. And what did we say AHA was for epi? Class 2B, I believe, right? Yep. So class 2B. So again, the science supports that waveform, good BLS, and airway management are way more important than any drug we're administering, but especially epi. So again, this is effective immediately. This is rolling out now. We will be preparing the arrest packs as we speak. Actually, we're getting all this ready for you guys. So it's in Dropbox. Physical copies are printed. The labels are ready. If you have questions, reach out to myself or Brenda, and we're happy to help you. You got anything else?
Yeah, you want to hit also on VFib delaying the epi when they're on refractory. I think we missed that.
So this was
Sorry.
an interesting one, and I'm glad she mentioned that. So another thing that is coming out in the new update on the state here. So if you have VFib or VTAC, so you get in, patients in arrest, CPR, we've got the monitor on, they're in VFib or VTAC. Obviously, our first move after those first few minutes of CPR is to charge and shock the patient. If the patient, you've got another 2 minutes of CPR, when you reevaluate, if that patient's still in VFib or VTAC, then they're recommending the delay in epi administration until after that second defibrillation. I think it's just a good thing to have in your mind to understand that we aren't bolusing epi, so I know that could get a little complicated, like do we start the fluid or not? But if you have a VFib, VTAC patient and they're refractory to that first shock, consider holding off. You can go ahead and get your access and hang the epi, but consider waiting until that second defibrillation before you start the epi.
Yep.
Anything else on that?
Nope, I think we got it.
And again, if you did start the infusion prior to that second defib, it all depends on how things time out. You may be in there and not realize they're refractory before you've already started the infusion. And now that we're not dosing epi, I think that speaks even more highly to this note here. It's not going to create that myocardial demand or oxygen demand on the myocardium. So I think it's going to be all around a positive thing. We've got a lot more innovative things we're going to roll out in the protocol update coming up. And we also have some other ideas around cardiac arrest and how we can implement some other innovative things while working these and try to get some more saves. So appreciate all your hard work. Again, let us know if you have any questions. Good.
Thanks. Don't forget, APS, CPS due May 1st and in service May 16th. See you there.
See you there, May 16th in service. Bye, guys. Done.